All right. Welcome, everybody, to today's SURSAC meeting. As usual, I'm just going to cover some disclaimers and go over the public comment policy real quick. So there's going to be, we'll start with disclaimers. So this meeting is being recorded and live streamed on TVW. It will be shared on the State v. Blake ESB 5476 webpage, so you can watch it later if you need to. And the recording is open to public disclosure, so please do not disclose any private or confidential information during the meeting. For public feedback, we are now offering opportunity to provide public feedback at the beginning and the end of the meetings, 10 minutes each. And each person will have 3 minutes to provide feedback if you want to. If you are not a committee member and you would like to make a comment during a particular discussion, what you need to do is just raise your team's hand for facilitator awareness, and then public comment on that topic will be invited before moving to the next item. Feedback that is not provided during the meeting can also be submitted via email at any time to hca ESB5476@hca.wa.gov. All right. And with that, I will go ahead and move into roll call. And then, Michael, if you want to have any welcoming comments, I'll just pass it on to you for that. All right, so Michael Langer. Sorry, present. All right, Amber Leaders.
Yeah, good morning, I'm here.
Oh, good morning. Senator Dingra. Senator Braun. Representative Davis. Representative Griffey. Caleb Banta Green. Don Julian Saucier.
Good morning.
Good morning. Chanel Wolf. Alexi Orr.
I'm here.
Good morning. SURSAC members, if you want to unmute yourself now to make it easier when your name's called, feel free to do that. Amber Daniel.
Hi, present.
Good morning. And I know Brandy Flood is not able to make it today. Stormy Howell.
Good morning, present.
Good morning. Chad Enright.
Good morning, I'm here.
Good morning. John Hayden. Sarah Melfi Klein.
Good morning.
Good morning. Sherry Candelario.
Good morning.
Good morning. James Tillett. Christine Lynch.
Good morning, present.
Morning. Sarah Gillard. Donnell Tanksley.
Here.
Good morning. Malika Lamont.
Present.
All right, good morning. Kevin Ballard.
Present. Good morning.
Good morning. Addie Adwell. Hunter McKim.
Good morning, I'm present.
Good morning. Representative Taylor. Representative Mossbrucker. All right, that concludes the roll call. So Michael, I hand it over to you for opening comments. Oh, you're muted. we can't hear you still. I don't know if it's because you're muted on your phone also, or
I think this is gonna.
yeah, now we can hear you.
I don't think it's gonna double up. Can you? Can you hear me now, Michelle? Okay, I'm gonna try to call back in because I'll lose connection. So I'll keep this really short. Welcome. I hope everyone had a great weekend. I hope you enjoyed the Super Bowl, if that was in your plans. And you'll notice that our legislative members are not on today. I think that's pretty obvious that they're in session. We'll talk about session in just a few minutes and kind of give an update in that regard. But again, I'll keep this short and just really appreciate everyone being on this month. We have a very full agenda, and then we'll take your agenda items for next month under consideration as well. So I'm going to go ahead and turn it back to you, Michelle.
Great, thank you, Michael. And so here's where we are going to start our first public comment period. So we're starting at 9:08. We can go until 9:18, 3 minutes per person. And Blake is going to facilitate this portion. So if you want to make a public comment, please go ahead and raise your hand now, and then Blake will go ahead and facilitate that discussion.
Thanks, Michelle. Good morning, folks. Would anybody like to comment? Right, again, if you would like to comment, please just go ahead and raise your hand in chat, and we will let you do so. Okay. New last call for public comment. Okay, Michelle, should we move on?
I think so.
Okay. Thanks, folks. Next up, Michael, you ready for legislative updates? Yeah, not hearing you.
Thank you.
Okay, I will try it this way.
We can't hear you.
Yeah. Mike, you may
Yeah,
want to
that's-
go ahead and try to restart.
Oh, here we go. You can hear it now,
We
right?
got it? Yep.
Yeah.
Perfect.
Yeah, I'm gonna have to try calling in again after this, Michelle, if this holds out, and then just make sure that my phone number gets admitted. That's the only thing I could think is happening because it was working earlier. Quite halfway through, a lot has happened already. Many of you have been tracking the bills, particularly those that are very directly associated with SURSAC. We have reviewed literally hundreds of bills as an agency. We're tracking about 80 to 100 right now that are still active related to behavioral health, many of those related to substance use disorders. And from prevention to outreach and engagement, treatment, harm reduction, recovery support services. There are bills that sort of run the gamut across all of that. Michelle has been doing a good job. Thank you, Michelle, of getting out updates since our last meeting. I think you've probably seen more communication and hopefully some tips on how to track the legislative session yourselves a little bit better. But a lot of activity for sure. last Monday in Law and Justice. Michelle, am I with you?
You cut out there for 5 seconds or so, but you're back now.
I'll go quick. I'll go quick and see if I can get this. 5467 and 5035. What we know is the end of last week, 5536 passed out of committee and is now headed to Ways and Means. It was amended to include many of the SURSAC recommendations that were initially embedded in 5624. So if you look at substitute Senate Bill 5536, that's where you're going to see much of the language that we had put forward from the SURSAC committee. So I would kind of guide us there. Also, real quickly, update wise, the policy cutoff is the 17th in the original House. So policy cutoff on the 17th. It's 4 days from now. Fiscal cutoff is the 24th. And we're all driving for sine die on the last day, which is April 24th. So a lot of session to go yet, but much of the many of the recommendations have been picked up one way or the other. You're probably interested in the legal aspect that we spent so much time on in the fall. Right now, it is it's in Substitute Senate Bill 5536. And there's language about gross misdemeanor and misdemeanor in there. So I will pause at that point. Hopefully that held out, and see if there's any questions regarding legislation. Hearing any? So I think
Yeah. Michael, you cut out again, but it sounded like we're about to move on to the next item. So
yeah.
Okay.
I was waiting for questions. I don't hear any questions, so I was going to have Blake go ahead and move on. But
yeah, we don't
I'll
see
try to
any,
get.
so.
Okay. Thank you.
All right. Thanks. If you have questions, hopefully we'll have a little bit of time for that later. Okay, next up, Recovery Navigator Program overview. We're Ryan, welcome, and Suzanne. So whenever you're ready to go.
Sounds good. It's good to see everybody on this lovely Monday morning. Hope you can hear me well, and I've got my screen up to share. My name is Ryan Keith. I'll be going over the Recovery Navigator Program presentation we're calling RNP 101. I am the Recovery Navigator Program Administrator within the Healthcare Authority in the Division of Behavioral Health and Recovery. And then as you see on the slide, Suzanne Straub is kind of my cohort in this. She's the Behavioral Health Program Manager within the Medicaid Programs Division. And so together, we kind of do all of the Healthcare Authority side of things to support Recovery Navigator Program. Some of this material may very well be familiar to folks who are either working within the program, or familiar with it through your SURSAC work already. So we have some time at the Q&A at the end. So be aware we'll give you some opportunities to ask questions on stuff you're seeing throughout. But I'll go ahead and get started. So as an overview, this really goes over what Recovery Navigator is. We want to provide that overview of the work that's been accomplished so far in the partnership that we have with the Behavioral Health Administrative Service Organizations, or the BHASOs, and the role within the Recovery Navigator Program, that RNP we're going to call it throughout. We're going to go over how we've really built this program on the core principles from Law Enforcement Assisted Diversion, the LEAD program that's been really doing excellent work for many years. So we're building from that. And those principles have been key in forming the uniform program standards. And we want to share where we're at with the program implementation, as well as the data that we've been discussing through a lot of meetings over the past year. And so the Recovery Navigator Program is a statewide effort. It truly is. It's active in every county in the state. And it's done in partnership with the Behavioral Health Service or Administrative Service Organizations, those BHASOs, to provide the community-based outreach, intake and assessment, referral, and long-term intensive case management services to individuals with substance use disorder, including individuals with co-occurring substance use disorders, mental health conditions who are referred to the program. So the RMP framework was established. It's created a new system of response and care for people who have unmanaged behavioral health needs, deep experiences of complex trauma, cognitive disabilities, poverty, as well as lifelong experiences of marginalization. So it's really meant to help those that are frequently encountering law enforcement, but not only them. It's folks that may be at risk of becoming connected with law enforcement, engaging with them. We want to help these folks to get the services and referrals that they need before it becomes an issue where they're really getting past the point of no return. So RMP serves people who are at risk of arrest, or those who have already been involved in the criminal legal system. RMP connects social services to individuals who intersect with police due to simple drug possession and/or people who have frequent criminal legal system contact because of unmet behavioral health needs. RMP provides referral pathways for law enforcement, emergency departments, businesses, and other referral points to access services. It's really anybody. We get a lot of community referrals, a lot of law enforcement referrals. They really want to get this individuals connected to services before it becomes a situation where there's no alternative other than for law enforcement to take them into custody. RMP staff work with local community resources to address the intersectional and holistic needs of the individual by addressing the social determinants of health, including education, housing, and employment, really a lot of those basic services for individuals that have had trouble navigating them or had a lot of frequent experience. They just need somebody to help them navigate that process. So this has been going over the last couple of years. The timeline that you see here discusses the process from July and August of 2021, where HCA convened a work group to create the RNP standards based on those lead core principles. After the Blake decision, after the end of session in 2021, there was a pretty quick timeline to get this up and running. You might have heard, at the time people were handing out cards to do these referral services. Well, that time has ended. As this timeline goes on, these programs have gotten up and running, and they're doing quite different services than they were in 2021. Through fall of 21, the BHASOs hired their regional RNP administrators, began developing their implementation plans, and then throughout the end of 2021 and into 2022, HCA and LEAD reviewed the BHASO plans, and once the plans were approved, the BHASOs began working on program implementation, began hiring staff, getting services in place through every county within their coverage region. From that time until now, roughly 241 staff have been hired around the state. So they're active, at least a team in every county. Staff have gone through onboarding trainings. The regions have formed the referral processes and developing some of the services that support those referrals. And they've begun accepting referrals, providing outreach, case management services, all of the activities that RNP provides. So all counties are now accepting referrals and are building on some kind of future developments that we'll go over towards the end. So for a lot of questions that come up, many folks know this already, but what is a BHASO? The Behavioral Health Administrative Service Organizations are under Integrated Managed Care, IMC. It's kind of an organizational structure that HCA has within the state. Most services for Apple Health are provided through managed care organizations. Some services, such as for individuals experiencing a mental health crisis, must be available to all individuals, regardless of their insurance status or income level. And so for this reason, HCA contracts with the BHASOs across the state to provide these services. So that's kind of the layer of organization in which they fit, from the individual to the statewide healthcare authority. The BHASO services include 24/7, 365 access to a regional crisis hotline for mental health and substance use disorder crises, mental health services that include mobile crisis outreach teams that are staffed by mental health professionals, certified peer counselors, short-term SUD services for folks who are intoxicated or incapacitated in public, and also an application of mental health and SUD involuntary commitment statutes that are available, again, 24/7, 365, to conduct involuntary treatment assessments and to file detention petition. So they're really involved in a lot of the same population that RNP serves. We wanted to work with them to make sure that that connectivity was included throughout our development. So the Recovery Navigator Program is based on LEAD core principles. And so these principles emphasize that RNP will be person-centered and designing care to support the needs, values, and priorities of the population being served. It required flexibility to meet a client where they're at, both in the recovery and physically, the location that they might be residing at. And it has an emphasis on the warm handoffs and the linkage to care as being essential to this process. So instead of waiting for the moment of arrest, there's an option for law enforcement to refer and connect the person with RNP services. This is an example of the social contact referral that's built into Blake and underpins everything we do with the Recovery Navigator Program. That statute that says, hey, you can refer somebody to services, or you're required to refer to services as currently written. That's where RNP fits into this whole process. It's not just here's a card, here's how to access services. It's like, let's get you connected with an individual. Let's call a team out to help you. And so harm reduction and trauma-informed care framework are guiding all of this process. RNP staff will use strategies and evidence-based practices aimed at reducing the negative consequences of the behavior with the individual directing their course of treatment. So that person-centered is really also at the core of this as well. RNP programs do receive technical assistance from LEAD staff, and that covers policy coordinating group and operational work group information, assistance with connecting with local law enforcement, prosecutors, city officials, etc., establishing referral pathway, and really any or all programmatic needs. The folks at LEAD have a lot of experience and expertise that we've been very thankful for, and so we're grateful for their partnership in this and their support in developing it. And we'll go over a little bit about what these work groups mean as well. So what we have when we talk about a policy coordinating group and an operational work group, the operational work group that's there on the right, this is kind of the more regular work group process where membership is composed of community partners, such as assistant prosecutors, public defenders, case managers, other service providers, tribal members, persons with lived experience, folks that really are working directly with the individuals that are under the case management of RNP. So the OWTs develop these protocols to ensure that program operations are reflective and consistent with the RNP standards. And they provide a common place to discuss the day-to-day activities where the partners and members can collectively monitor, identify, discuss, and address the operational, administrative, and client-specific issues that come up. Now, the policy coordinating group that's there on the left is a little bit higher level. So this is the policymaking and stewardship framework for the RNP. The membership for this group is composed of more senior members of their representative agencies. These are the folks who are authorized to make decisions on behalf of their offices, as well as law enforcement, public health agencies, mayor, county executives, et cetera, folks that are able to be more involved with the larger strategic goals of RNP and their impacts to the communities. So PCG members develop the local vision. They make policy level decisions and ensure that sufficient resources are dedicated to the program. They help coordinate kind of where those things might be coming at, not just on the day-to-day activities, but what's going on long-term. How is this going to benefit the communities that are being addressed? So as we're more than a year into the process, all 39 counties in the state have established both their policy coordinating groups and operational work groups. So we're seeing a lot of those results really come to fruition now that we're up and running and accepting referrals. So in terms of accepting referrals and what the individual experiences, it's what we call the golden thread of service coordination. So individuals that get referred to the RNP have a multitude of needs. Those needs have to be addressed to achieve stabilization and it sets the stage to address problematic activities associated with their quality of life. So the individual intervention plan is where we start. This is a culturally directed service plan created by the individual through a shared decision-making process with their case manager. So the case manager that worked with them to do some outreach, make contact, possibly many contacts before they decided to engage in case management. We just meet the person where they're at. If they're not ready for recovery, we're not going to make them do that. But we want to get to the point where that seems like a beneficial thing for them, and we'll help them through that. Now, those case managers have a caseload. Excuse me. So the caseload should be approximately 20 people. And this is a blend of very active individuals and those who still need that proactive engagement in the field. The caseload can vary somewhat depending, of course, on the region and the population that's being served. In terms of caseload, we do sometimes have those very active engagement individuals, as well as some that maybe continually, you do the outreach and they're just not interested. That's okay. They're still on the caseload. We still, try and make contact with them and let them know what's going on, find out if anything has changed since the last time that they were engaged. The case management classifications have 4 classifications and then 3 levels of engagement within those. So when we talk about outreach referral, that means that a referral was made, formal intake wasn't completed, they're not interested in services, but they at least know that the RMP staff is out there. Maybe they've made some contact. If somebody is listed as being in an outreach status, that means that a screening was completed. The individual's maybe not interested in service, but they indicate, well, maybe I need some occasional support. Check in with me again. They're very receptive to it, but maybe they're still wary and they just don't want to get there quite yet. And then when we get into the more formal case management, light case management means the individual is interested in basic services such as housing, something very straightforward, and they're considered a program participant at this stage. Once they enter that light case management phase, that's when we start listing them in that specific way. When they get a little more engaged with the intensive case management side, that means that the individual needs more intense case management. They have several comorbidities. They might be experiencing homelessness or have other issues, but we're helping them get actively referred to services. And that intensive case management is really where we see a lot of folks, that's where we want them to get to, is getting the help and getting that referral to services. And so next, I'm going to go over a little bit of the data. What I've got for you here, it's a very early look of what we have as the most recent quarterly data from October through December 2022, quarter 4. These are based on workbooks that were submitted just last month in January. This is the most recent time period that's available. This is a kind of our most recent fully operational time period as well. Some of the data that we had from July through September, we had some regions that were not fully staffed. So we're a little more excited about these numbers as being more of a baseline. Now, we will be presenting on the actual data collection more at the next monthly meeting in March. So a lot of this is preliminary. You will get a lot more of it as it goes forward. So understand some of these are a little bit drafted, but from that quarter, we saw almost 6,000 total referrals. We saw 519 from law enforcement and 5,397 as community referrals. So that kind of 10% ratio from law enforcement is roughly similar to what we saw in the previous quarter. So we think that might be a little bit more of a through line, but we'll find out as the data collection goes on. We're pretty excited about those numbers. They're really all over the state. They see success in getting those referrals. Really a shout out to the RMP teams for doing that because they do some pretty amazing work. What I've got for you here is our internal dashboard on the referral and outreach data, just to show you some of the numbers as it's going along. So this slide shows the data from initial engagement. So this is where receiving those incoming referrals, whether from law enforcement, from a law enforcement officer or from a community source, this demonstrates where RMP teams interface with the community. So we've got our total referrals, the breakdown between law enforcement officers and others, the number of follow-ups and outreaches as they were categorized at this level of engagement, and then a breakdown. So you see roughly 2/3 of those are still in outreach status. contact was made, but maybe they weren't interested in services. And then that remaining breakdown, light case management, intensive case management. So we're getting there. We know that the population, needs to be converted from that outreach status into case management. Now that's kind of the crux of the process. So this slide, a couple of caveats on this one as well. It includes a lot of referrals to services and some of the data that we get back. Now, on the version that we'll send out to committee members, some of this may be adjusted. There was some requests from our internal data team to do some data suppression on the smaller numbers to list them as other. So this field breaks down the kind of the next phase of the R&P engagement with the initial contact. So this is working with the individuals to build the rapport, and it helps get them connected to services, whether it's the lighter intensive case management. This aspect of the program will continue to grow as the client base expands over time. So these numbers aren't the exact same as we saw with the initial engagement. And you'll see that some of these categories, like I said, there was either repetition or a breakdown from the referral teams listing, in some cases, it was a referral to services made, yes or no. Sometimes they would list what the referral was. So this is part of the challenge that we found in working across the state, is finding the individuals and then figuring out how to track exactly what they're doing at this level. Now, we get a lot more specific data. And like I said, a lot of that will be gone over at the March presentation. But just wanted to give you that heads up that some of this may change in what we send out. But we'll have that available. And so next, I wanted to share a success story. Stories are really at the core of a lot of what we do within R&P, the stories around people's recovery to give them hope and help them along in that process, to share with others and let them know that recovery is real. So this picture that we've got up was a picture taken by Aberdeen Police Department Officer Laura Neal, who shared and just said they wanted to say thanks for helping this program participant this afternoon. This is something that they sent in to us. We collect the success stories. I know my BHASO partners are probably tired of me asking them every time we're in a meeting. I'm like, hey, do you got any success stories? I want to hear what's going on in your community. What these folks are Recovery Navigator Program teams doing referral and outreach, helping somebody that they've been working with. So it's taken to try and protect people's identity. Didn't want to expose that, but just some thanks from the community that's being impacted. Now we also have a story from Kittitas County. Program participants sent in a letter, handwritten letter to the R&P administrator. I'll read it out for you if you'll bear with me there. The letter begins by addressing, to whom needs to hear success as possible. My journey started with a simple hello and I need help. I was released from the Kittitas County Jail with one set of clothes, flip-flops, a list of resources, and a non-working phone. I was helped with one night in a motel by a church. I reminded myself that failure is not an option. Once I was safe in my motel room, I picked up the list of resources and began calling. The first place I called was Merit Recovery Navigator Program. I felt doubtful that I would get help. This program ended up changing my life. I began working with Melissa, Vicki, and Anthony, and they helped me with start to finish a drug assessment, checking in with my probation officer and DOC, connected with NA and AA meetings. I was provided with essential need items like hygiene, clothing for interviews, and other things. I was assisted with scheduling DSHS appointments, resources for a domestic violence shelter, and most importantly, a listening ear. I showed them that I wanted to change, and I kept my word. They backed me up and assisted me with everything I needed. I was able to complete tasks that otherwise would have been perceived as overwhelming. And without their help, I feel it could have been close to impossible to accomplish these tasks without relapsing. Today, I'm clothed, housed, and striving to keep thriving in outpatient and inpatient treatment. Thank you. So these are the kind of stories that Recovery Navigator makes possible. We get them in again, every county across the state. We hear stories from Recovery Navigator Program teams who are saying, the peers that are working on these teams have found a career that they didn't think was possible in their rural county. They're working with communities of folks that they didn't think it was possible to have a job in this field, and they're happy doing it. So we hear it from the participants, from the teams. It's a very positive outcome that we've got. So I'm very happy to be able to share it with you. And in terms of what's next, what we're building on in 2023, now that we've got really operations up and running, we've got referrals being accepted across the state, we're working on expanding coverage, 24/7 coverage to make sure that all regions are going to be 24/7 by July 2023. And this is a targeted expansion to respond to after-hours referrals specifically from law enforcement. Several regions are already responding to referrals after hours. Some have it set up so staff who are on call after hours receive a stipend. Others have staff work split shifts. The intent for this is to respond to law enforcement referrals, follow up with outreach the next morning. We're not necessarily sending out in-person teams overnight, but they are able to accept the response, make that contact the next morning as soon as they can follow up to make sure that the individual gets supported. This could be an hour's drive from the local population center. Some of the more broadly geographic rural counties have teams that need to travel quite a bit. So we want to make sure the expectations are there and being addressed. But we know that law enforcement is our primary goal. We want to make sure that we can support them in accepting those referrals, let them know the resources are there so that they don't need to take that individual into custody in the moment. And in terms of resources, we've got some stuff up on the HCA website to learn more about the program, any updates, and the work that's being completed by HCA and their partners. So we've got the State versus Blake site that you're probably familiar with that supports SURSAC as well. I know on the version we'll send out, it will also have the links to the LEAD National Support Bureau. Again, thanks to them for all of their great work in kind of leading the way on where this program wouldn't exist without a lot of their existing work over many previous years. And in terms of questions, I'll kind of open it up for the Q&A at this point. I've got my information up there on the screen, my email, as well as Suzanne's. Welcome to email us at any time if you have questions about this, as well as the larger 5476 email, and we can help coordinate services that way. But yeah, I'll go ahead and open that up in case there's any questions.
Thanks so much, Ryan. There is actually a question already in the chat. Caleb's on his phone, so it's harder to participate, in video and whatnot. So he asks, Ryan, what do 3,000 plus, quote, contingency management, unquote, mean? Discussed, enrolled, actually started, completed. That's a large percent and numbers, so interpretation would be helpful.
Yes, and I actually had that similar question before this presentation. Some of this I'm going to defer to our upcoming presentation in March, where some of these categories are going to be gone over in more detail. The contingency management aspect that is part of the ongoing case management. I had a similar question where I wanted to see, like, well, these are larger numbers. How are we breaking that down both geographically and in terms of services? So I will follow up with more information on that in the March meeting. And I'll see if we can get a little bit more on that as well, because the data that we collect in the workbooks, we literally just got this at the end of January and went through it and had that slide put together last week. So I apologize that I don't have the in-depth explanation for you right now, but we will follow up with that.
Great, thank you. Other questions, please feel free to raise your hand.
Here we go. All right, we have a question from Malika. Malika, go ahead.
So I noticed that there was a lot of unknown under the demographic portion as far as race and ethnicity, and the LEAD model, part of what it was designed to do was to address disparity, and it has been proven that it does do that when it's implemented fully. So I was just wondering what's going on there, is how are folks engaging with gathering that information, and what do you think can be done to address that huge unknown?
Yeah, no, and thank you for that, because that is an important aspect of the Recovery Navigator program as well, to try and identify where the impacts are happening within the community. Part of the challenge with that is, of course, is that the data collection is voluntary. If the individual does not wish to provide that information, or if they decline to specify very specifics of it, those folks are going to get listed as unknown. And in making more regular referrals, a lot of times that inflates the numbers. If you talk to one person 17 times and they say no every single time, you got 17 others in there. We have been working with the teams to try and figure out how can they engage with individuals, what dialogue works to try and get some more information from them. It has been a challenge. It's something that we do want to see addressed over the long term. Whether there's specific regions that are working better than others, if there's some that are having greater challenges, that's part of what we're looking at with the long-term vision for the data. We know that this was one of our first more full quarters that we have the data available. And we're trying to use that to change our processes and improve them so that we have more access to identify where the challenges are and then adapt the services to truly work around them. A lot of what we've seen with so much of this data is, we've been doing this for just really 1 year, or even less in some regions. And so trying to adapt is an ongoing process, and it's that long-term investment in what we can do with the data to really make the services better.
So I just want to be clear that I'm hearing you say that you've heard from folks that that are doing the work in the field that people are denying, like not answering those questions. Like you've been hearing that anecdotally a lot, or that is just an example of what you think could be leading to it. I just want to make sure that I'm clear.
Oh, it's more of an example from the workbooks themselves. We do actually see the data that gets collected. One of the categories within the workbook, lists other or declined. So if we can see in the data that is submitted that somebody declined to answer the question, we can see that. And that's going into that other category. So it's not really anecdotal in that sense. We're really saying, okay, you're getting a lot of declines. Let's strategize about that. What can we do to try and improve that engagement?
Okay, because other and declined would mean that, something else could have happened too. So just from a data perspective, I think maybe splitting those out might be better, because then you can get at if there's a training need that needs to occur, so that folks can be asking things in a respectful manner that people feel like engaging with and answering.
Yeah, and we'll certainly get into a little bit more about those specific categories. I will say I'm not looking at the workbook right at the moment, so I can't tell you exactly how those questions are broken up. But that is a very good point, that if there's an opportunity to split those up to get more data, always looking to improve that.
Okay, thank you. Amber.
Yeah, I kind of am in the same vein as Malika here this morning. I noticed when you were talking about the referrals and how, about 10% of them were coming from law enforcement officers and the rest were community referrals. And I was like, we get a lot from, the criminal justice system, not necessarily law enforcement officers. But I think it's really important to break that down as far as which referrals we're getting from the court system, from defense attorneys and stuff like that, because I don't know if that would really necessarily be considered a community referral. It's not like a business or a nonprofit or, those these are coming from courtrooms.
No, and that's very true. That is something that we will be exploring more in the March presentation that breaks down the data in more detail, because you're absolutely correct that referrals from the court system, from other aspects of what we refer to as the community, is distinct from law enforcement officers specifically working with an individual and then declining to charge them with something and making a referral in lieu of that. So that's very specifically what we're really highlighting with the law enforcement referrals specifically.
Yeah, and there's a lot of referrals that we get from the court system where people are still getting charges dropped because they are participating in lead, and that's important to note too.
Yeah, so there's been a few more questions in the chat, so I'm just going to go ahead and they've already been answered by Suzanne in the chat, but just for so we're all on the same page and getting the same questions answered, just want to cover those. Let's see. Do the navigators work in conjunction with the PATH and peer Pathfinder programs? The answer is yes. The outreach teams often work for the same organization. They are well connected with each other. And then Kevin Ballard asked, are hospital emergency rooms partners in the R&P program and contributing to referrals? Or is law enforcement the only means for referral when patients are in crisis at a hospital emergency room? The answer to that is that law enforcement is the primary target for referrals, but community and social contact referrals are always welcome. Some regions have a great partnership with their local hospital social workers and receive referrals from them. Did I miss anything? Questions in the chat?
I think that was all the questions.
Okay.
Okay.
Yeah.
Any more questions for Ryan and Suzanne?
Thank you again for the opportunity to come present and the questions and the feedback. Hopefully we'll be able to incorporate that and be a little more responsive in our more formal data presentation. I know a lot of the categories that have been developed to date were done based on previous SURSA recommendations and the guiding legislation. And so being able to really define and dig into that is something we're really looking forward to going forward. Now that we have a lot of these systems in place, just very excited to be able to provide and share that and share all the great work that these teams are doing.
Awesome. Thank you so much. Appreciate you being here. All right. Okay, next presentation is State Housing Programs Overview. So Melody, Wanda, and Michael, if you are ready, that'd be awesome. Hi, Melody.
Good morning. I think I
This
will.
is Wanda. Is Melody going first?
Melody is first up, yeah.
Okay.
So hopefully you are seeing my screen.
Not yet.
Looks like it's coming up.
Yep, there we go.
Yeah.
Awesome. Good morning, everyone. I see a lot of familiar names in the chat, but for introduction purposes, my name is Melody Pazalt. I'm the Managing Director of the Office of Apple Health and Homes within the Department of Commerce. Folks may have recognized my name. I have been with Commerce just a short time. I'm really familiar with the behavioral health system, having been with the Division of Behavioral Health and Recovery prior to being with the Department of Commerce. And so I really want to say that I feel like I am a behavioral health person embedded within the Department of Commerce and hope to be a resource to the behavioral health community. And so I'm really excited. And this is really an opportunity to share the lessons that I've learned about housing in the short time that I've been there, which is just about 6 or 7 months. So it's really interesting to be at Commerce. They do such a variety of things, and it's just so amazing, all of the different parts of Commerce. They do infrastructure and broadband. Michael, we might want to get you some broadband and help you with some of your technology challenges. So they do broadband infrastructure, they do energy assistance, they do small business assistance, they do crime victims advocacy and public safety. They have a lot of stakeholder, they do economic development, they go and try and go into other countries and try and bring businesses to Washington State. They do a ton of assistance to counties around growth management. They also host the grants to help build behavioral health facilities and help communities. They also do a lot around housing and homelessness. And I am in a new division that was they did some restructuring this last summer, and I am in the housing division. And I'm going to share in just a minute about the restructure. Housing is complicated, it is there, it's a system, but there are so many different federal, state, and local resources. And when you talk about the different types of housing, from owning your own home and to shared housing, to single room occupancy, to project-based housing, cottage housing, tiny homes, transitional housing, there's master leasing, there's accessory dwelling units, scattered site housing, recovery residences, and my personal passion, which is permanent supportive housing, which is, I'm going to kind of focus on that a little bit more today, which is really actually a placeholder for even, I think I'm hoping to come back and talk a little bit more about a specific initiative next month with the Healthcare Authority and what's called Apple Health and Homes. But just wanted to just give you a little bit of a preview about how it's really almost like talking a foreign language, because there are so many different federal, state, and local resources that it's like going into a foreign country and talking acronese, because there are so many of these different acronyms, and I apologize for the acronym soup here, but I wanted to just sort of display how complicated housing is. There are federal, state, and local services. There are federal, state, and local rent assistance programs. There are federal, state, and local capital, bricks and mortar, to build more affordable housing. And then there's also this gray area that there are residential home-like environments that are getting, I think, also that can be construed as homes, like adult family homes, but those are residential facilities. And so there's a lot of menu of options, and I think we are at the opportunity where we are at a paradigm shift, where how do we match people with the setting that they need to be successful? And I think that that's where I'm really excited to be at with Commerce, where we're really starting to have some of those conversations around this paradigm shift with matching people with the environment that they need to be successful. So the spring, Commerce did a little bit of restructuring and actually created a housing division. Karina Gregoris is our assistant director. Ted Kelleher is our housing policy director, and so he is leads the team around policy. And then there are 6 units, distinct units, and this is a wonderful little programmatic org chart that kind of talks through what all of our programs are within these units. I'm going to quickly go through a lot of these programs, because these are some of those federal and state programs that we manage within Commerce. I'm going to put a couple of things in the chat that I think are really, that I have found to be really helpful. One, whenever you're thinking about navigating the homeless housing system, and one of the biggest differences, I think, between the behavioral health system and the homeless or housing system is that in the homeless housing system, everything's done at the county level, or majority of things are done at the county level. Every county has a plan to address homelessness. And those plans to address homelessness, if you want to get connected to what's happening in your local community to address homelessness, every county has a plan to address homelessness. And I'm going to put the link to those county plans. The other thing is that every county has a performance plan and how they're measured on how well are they doing to address homelessness. And so there's also a lot of performance measures to address homelessness. And so our data and performance team actually have done quite a bit of work, and we have in the country, we actually are leading the country on our data and performance measures on how are we doing on addressing homelessness. And so I'll put that link in the chat as well. The other thing, the first line of defense around how do we access this plethora, whether it's federal, state, or local resources, is coordinated entry. That is our first access to the homeless housing system. And so there is actually a list of what is that first access point in every county to accessing the majority of resources. It's not a perfect system, but it is the system that the federal government has directed us to use. It's sort of a triage system for the homeless crisis system, sort of like the 988 of the homeless system, and every community creates their priorities for homelessness. And so that is what's called coordinated entry. As we talk, and I'm going to quickly go through these slides and introduce you to these different units. So Ted Kelleher, our housing policy team, they implement our legislative support, also our right-of-way initiative, and our Affordable Housing Advisory Board. We have a home ownership unit, a unit that's dedicated to helping with home ownership. I'm so excited to work in collaboration with them. And how do we help people actually buy and purchase their own homes? I think it's a program that we have not done enough to really help people buy their own homes. And so I'm going to be working very closely with Anne to see how we can create a home ownership program for people with behavioral health conditions. The Home Housing Assistance Unit, the HAU unit, they manage what is called the Consolidated Homeless Grant, the Landlord Mitigation Program, a lot of the federal programs, again, a plethora of all of these different resources. One of the main funding streams that we have in Washington State is what's called the document recording fee. It's a funding source that's a fee on, there's actually 4 different document recording fee programs in Washington. Some of those are at the county level, some of those are at that come to the state. We then turn around, we keep a portion of those. Some of those are sent back to the counties. It is just a complicated system, but again, really get connected to your county. And then those funds are sent back to the county. The other thing I failed to mention is we have 5 communities that do get funds directly from the federal government. Those are called continuums of care, COCs. The other remaining counties are what are called balance of state. Those are other key pieces or as part of this foreign country language that I've had to learn being in this foreign country of housing. And again, I know this is a lot of information in a very short amount of time. So I'm going to keep cruising through this. Office of Homeless Youth is another unit, data and performance. Multifamily housing, this is our capital program. So Nate Lichty oversees our capital program to build more affordable housing. And if you're watching the news, there's a housing shortage. We have not built enough housing. We just have not built enough housing, which is part of the housing shortage, the homeless crisis that we have in Washington State. When we basically say what's going to solve homelessness? Housing. I like to hear Ted Kelleher talk a lot, and he says the only thing that's going to solve homelessness is housing. I like to add on, that's not going to solve that individual's problems. That individual still may have to deal with the challenges of ongoing behavioral health conditions. There's still poverty. There's still all sorts of things once they get into that housing. So yes, the only thing that's going to solve homelessness is housing, but that we still need to provide ongoing support to help that individual. And so this Housing Trust Fund is really about building more affordable housing. And that leads me to the Office of Apple Health and Homes and permanent supportive housing, which is a specific model of housing where we really try and bring 3 legs of the stool together. It's really about capital to build affordable housing, services to wrap around that individual, and then rent assistance, because you can build affordable housing, but that individual still needs money to be able to pay for rent. We know that housing is part of social determinants of health. We know that permanent supportive housing reduces healthcare costs. And this is part of those three legs of the stool: rent assistance, services, and bricks and mortar. And if each of those legs are not developed at the same time, we have a wonky chair, a wonky stool. The Growth Management Act basically was charged with identifying how far behind are we with building housing. And so what was determined through House Bill 1220 was that we are almost 1 million units short of affordable housing or housing period. And so this is housing by different income brackets. And they did take a look at housing needs of people. And so this is what's called area median income for people that are the poorest of the poor, 0 to 30% area median income. That is almost 1/3 of the housing that's needed. And particularly people that need permanent supportive housing we need 116,000 units of permanent supportive housing in the next 20 years. And so that's part of the efforts that my unit is working on in partnership. And I'm going to stop there because I'm out of time. And just put that as a placeholder to be thinking about our next presentation, where we're going to be partnering with the Healthcare Authority and Department of Social and Health Services to launch the Apple Health and Homes Initiative that really brings those three legs of the stool together for a targeted population, which includes people with substance use disorders. So I'll pause there and turn it over to Wanda. See, I did it, Michael, in 10 minutes.
Awesome. Thank you.
Thank you, Melody. I'm going to share my PowerPoint.
And there will be time for Q&A at the end of all of the housing presentations. So just hold your questions to the end of all the presentations. Thank you. Go ahead, Wanda.
All right. Can you see my PowerPoint? Hello?
Yes, yes, we can.
Okay. Thank you. So I am here to introduce you to HARPS, or Housing and Recovery Through Peer Services. It's a housing first model of permanent supportive housing. Just kind of like what Melody was talking about. Research shows that within a year of being discharged from inpatient settings, people are 30% of individuals from psychiatric settings have been homeless within a year, and 50% of people with SUD inpatient treatment are homeless within a year. And that makes sense, because when you're inpatient, you can't really work and earn any money. And depending on how long you're in there, that could be a real problem with affording your housing or finding housing as needed. It also exacerbates the symptoms of mental health or substance use. The eligibility or the HARPS program has subsidies available for things, move-in cost and first month's rent, up to the third month's rent. We average about 200 or 2,500 per person. And that's usually spent over 3 months. There's supportive housing services that are based on the principles of supportive housing that include choice, flexibility, and frequency and intensity of services, separation between services, social services and housing, as well as access to housing. They also do landlord outreach. The HARPS teams are peers who have lived experience with mental health and substance use, and individual housing and housing related activities are among the many things that the peers do, helping individuals. And so eligibility is someone who has experienced behavioral health disorder, that's mental health or substance use or both, and who demonstrates the need for inpatient behavioral health care services, or individuals who are discharging from inpatient behavioral health care settings to homelessness, or individuals at risk of entering the behavioral health setting. And the homelessness, we include the broad definition of unstably housed, meaning couch surfing or doubling up with others. HARP's objective is to prevent homelessness for individuals leaving an inpatient setting. There's an RDA report that'll be part of the link when these slides get sent out. HARPS also offers housing services that include peer support, if I didn't mention that. And we have 10 areas, 10 regions of the state covered by our partners at the BHASOs, and some directly with the provider themselves. And for more information, you can write me at wanda.johns@hca.wa.gov, and there'll be a link to the fact sheet. And that's all I've got.
Thank you so much, Wanda. All right, Michael, are you here? Are you ready for your Forensic HARPS presentation?
Yep, I'm here.
All right, great. Floor is yours.
I'm glad I get to go right after Wanda, because the first thing to note about Forensic HARPS is that it is modeled after traditional HARPS. So most of what Forensic HARPS does is really, they share the same staffing model, hiring certified peers and housing support specialists. They have the same goals. I think really when I try to explain the difference, it may not be the only difference, but probably one of the most significant differences is the eligibility criteria for folks to receive Forensic HARPS services versus traditional HARPS. So that's why I go into first here, just talking a little bit about the True Blood settlement agreement. That is where Forensic HARPS comes out of. And Forensic HARPS teams serve folks who really are either True Blood class members or potential True Blood class members. I don't want to go too far back and zoom all the way out. But if you're not aware of what the True Blood settlement agreement is, in 2015, a court ruled that DSHS was taking too long to provide competency services. Those are competency evaluations and competency restoration services. And in December 2018, the federal court approved a settlement agreement related to the contempt findings in that case. And out of that settlement agreement is where we got Forensic HARPS. Sorry. I said a little bit about True Blood class members. Sometimes I think in our programs, there's a little bit of a misunderstanding, and we're all misunderstanding it all the time, because it's sort of like, if we only served technically True Blood class members, we would only be serving people who are literally in jail waiting for competency restoration services. But this program and other True Blood settlement agreement programs on a lot of different levels are trying to work with folks who either have gone through that system, the forensic or competency system before, and we're trying to help them not have to go back through it through some kind of diversion or resources in their community, including FHARPS. So that's where we talk about potential True Blood class membership. It's sort of like, does someone have a higher likelihood to find themselves in jail, charged with a crime, and have some issue of competency to stand trial raised? These are all the programs that were established through the True Blood settlement agreement, and they all work together to serve folks who meet the eligibility criteria I was just talking about. So in the red in the upper right hand here, you've got Forensic HARPS. And like I said, very much based on Wanda's program. We focus on helping folks overcome barriers to find and maintain housing. The teams are staffed with people who have lived experience with behavioral health. And those teams work with participants who are referred by forensic navigators, by Forensic Path, and some other ancillary ways as well, possibly through a crisis stabilization facility if someone is able to be diverted from further either law enforcement or court engagement. We really we have this in our contracts. We want our providers to adhere as much as possible to the permanent supportive housing model. And the principles of permanent supportive housing include choice in housing and living arrangements, the functional separation of housing and services, decent, safe, and affordable housing, community integration and rights of tenancy, access to housing and privacy, and flexible, voluntary, and recovery-focused services. It's important to keep all of these in mind, but if you can, keep the functional separation of housing and services in mind for a moment as I talk more about these principles. The reason for that is that in February, first of all, let me say in February of 2021, the programs, we allowed people to start to continue on through the program after the initial period. So in the True Blood settlement agreement, it stipulates folks should be receiving 6 months of housing voucher support and residential supports at $1,200 a month. The teams realized very quickly that that's not enough time for a lot of people to become stable in housing or to reach a more permanent housing setting. So we've continued to allow exceptions to the rule, exceptions to policy, and allow people to stay in the program for longer than that. And we're up to more than 40. I think this is the numbers here are a little old. We're probably closer to 50 extensions approved by HCA for people to continue on in the program. What I was meaning to get at with the functional separation of housing and services is that we have encouraged providers to use the housing subsidy dollars that are in their contracts in all different ways. And one of those ways we focused on, because it's different than so many other of the housing interventions, is through master leasing. And so that could be through the leasing of, say, an already existing unit in a permanent supportive housing complex. Some providers have done that and just, sort of obtained 2 apartments that are now available for Forensic HARPS participants. And that makes it a lot easier for release planning when folks are exiting custody. Because prior to having access to these master leased units, we were almost always needing to rely on hotel and motel, temporary placements in hotels and motels. So if you are familiar with, or if you're working with jails or in and around jails, sometimes you'll find folks are, they're going to be released from custody in a matter of hours, could be, 24 hours, 48 hours. So very quickly, the teams need to be able to find a place for someone to even just temporarily stay. And in order to decrease our need to rely on hotels and motels for this, a lot of the teams started to lease up different units, and in some cases, whole properties of units, for anywhere from 6 units to 14 in one larger one. That comes back to sort of the functional separation of housing and services. Is we really want to help our service providers, not become ad hoc landlords in a lot of different ways. So needing to add in contracts funding for property management or funding for maintenance and things like that, that we didn't really foresee prior to utilizing master leasing. The teams also work with folks to obtain more permanent housing vouchers. So, and one of those is through Commerce, the Community Behavioral Health Rental Assistance Program. Forensic HARPS was approved to be one of the long-term service providers, which allows folks who are eligible for FHARPS to be referred to CBRA. And so our teams really work to get folks on those longer-term housing vouchers. And should have mentioned at the beginning, Forensic HARPS is not in all 10 regions. We're part of the True Blood Settlement Agreement, and that being the case, we're in phased regions. So we're in of the 10 that Wanda held up, we are in 4 right now: Southwest region, Spokane, King, and Pierce. And that is it for me. There is some more information on the settlement agreement there. You can email the True Blood Task Force with questions about the settlement agreement or programs. And then here is my contact information for Forensic HARPS. Thank you.
Any questions?
Yeah, we have a full 15 minutes for questions now. So for any of the presenters, go ahead and raise your hand if you've got questions.
All right, doesn't look like there's any questions. Should we move on to the next agenda item?
Yeah,
Oh,
before
there's.
oh, sorry.
Okay.
Is there
Thought
a
we
question?
had a question. Sorry.
Oh.
All right.
I see questions or hands raised.
Yeah.
I see one. Is that all right all right.
Yeah.
Deontay. Yeah, Deontay.
Can you hear me okay?
Yes.
Yeah, this question is for Michael. Thank you very much for your presentation, or Mr. Donovan. I loved your presentation. I loved how it's throughout the True Blood focus. I loved how it was going towards people that have been incarcerated, as well as people that may or may not deal with mental health. But I wanted to know: is there any chance that are there any programs that you have that'll be based with advocating for LGBTQIA community members? Will that somehow, is there any way to get that added to the True Blood or a part of that family of advocacy, if that makes sense.
It's a really good question, and you know,
because it kind of
I
seems like that's one of the intersections that's usually missing,
mm,
where it's like making sure that LGBTQIA community members are kind of prioritized in that space. I don't know, just a thought.
no, it's a good question, and I think, you know, when I think of that, and when I think of the LGBTQA as a community, I don't think of that community as separate from True Blood class members, and I guess we don't know enough about True Blood class members yet in data to be able to say that there are more or less of, I think we have very minimal data, sort of even on race or ethnicity when it comes to competency restoration. So I love the idea of focusing more on any group who finds themselves more often than not at the intersection of behavioral health and the law. So I'll continue to think about that. There isn't anything right now that's saying we're going one way or another and towards this community more than that community, other than folks who find themselves charged with a crime and have competency questioned. So I hope that helps answer. It's probably not a clearest answer, but thank you for that question.
All right, Malika.
That question, and this is for all of the people that just presented on housing programs. I mean, for years, the point in time count, which is, you know, flawed in so many ways, but has demonstrated that LGBTQIA individuals are disproportionately homeless and experiencing, and I think that if we were looking and collecting data, we would see those intersections with law enforcement and other behavioral health issues, mental health, because we know that trauma manifests as that oftentimes. There are not, many of the low barrier, at least in my community, in Southwest Washington and Thurston County, most of the people that receive funding for shelter are actively discriminatory against LGBTQIA people. And I think that that is something that is true in many communities, because unfortunately we've seen, you know, a strengthening of religious rights in the sense that people can discriminate against people for their sexual orientation. So I'm just wondering, what is the state looking at to do in response to that with these particular programs that were outlined today? Because having coordinated entry is a delay. That means there's no low barrier access.
You want to take a
So
shot
this
at
Melody.
answering that? Thank you, Melody.
This Melody from, so I can tell you, yeah, hi Malika, great question. One of the tools that the Commerce uses instead, you know, the pick count is just a 1 day point in time count, but really actually what they use is what's called a snapshot count, and they use administrative data to get a better picture of the true understanding of homelessness. And so I'm trying to find the snapshot report that shows, and I'm not sure if the snapshot report does identify the LGBTQ community. So I'm trying to find that information on the snapshot report. I know that the Office of Homeless Youth is really concentrating on priorities I think that's one of the #1 reasons that we see homeless youth. I think that's so I would love to really get you connected to Kim Justice. I think that they're really trying to do a number of efforts to address homeless youth that I think that that's the highest number of homeless youth that are in the LGBTQ community that come out and experience homelessness. Or so I know that there's a lot of efforts that they're doing. I also, would say populations that are LGBTQ, I think it's also, if you're experiencing discrimination in housing, that is a protected class, and that's a fair housing right. And so then that would go over to the Landlord Tenant, Act. And so be familiar with what your rights are around fair housing, and so as a protected class. And so there are some resources and information to become familiar with your rights. And so the Pathways to Housing site has a lot of great information around becoming familiar with your rights as a tenant. And I'll put that information in the chat, and then I'll put the link to the Office of Homeless Youth in the chat, because I know that they're doing a lot around youth and the LGBTQ community. Oh, and Jim can probably put the snapshot data in the link.
Go ahead, Jim.
Oh, hi, everybody. I'm Jim Mayfield. I work at DSHS Research and Data Analysis Division, and we pulled together the numbers that Melody was talking about for the snapshot report for Commerce. Just real quickly, the data we use is from administrative data systems from all over the state, none of which systematically collect information on identity or orientation. We're pretty much limited to male, female for most of the work that we do. That's changing, but right now that's a limitation we have based on the data we use. But Commerce has those reports on their website as well, and I'll find some links to put out there for everybody.
Thank you. There's Lee got another question. Do those rights apply to shelters? You're muted, Melody. Thank you.
Oops. You'd think after 3 years we would have this down, but the landlord tenant law would not apply to shelters, but I would think there would still be they couldn't discriminate based on LGBTQ. So and that would the source of funds should, in the contract should, preclude them from discriminating on how they get paid. So there should be policies around discrimination based on the sources of funding and how the shelters are paid. If they're paid through public funds, they can't discriminate.
Well, they do. I wish that was true. I mean, but we know oftentimes that doesn't stop people from discriminating against folks.
Maybe Melody and the HCA team together, maybe we can work offline to get some resources if you do see that. You get particular cases or particular shelters, who you might call or reach out to. And then Michelle can put that back out afterwards. So thanks for the question, Malika.
All right, Jim, your hand's still up. Did you have more comments? Any other questions for the presenters today? Okay, no worries. Okay, so next agenda item is our public comments here. We are starting at 10:31. So please, if you want to make a comment, raise your hand and we will call on you. So again, time for public comment. Please feel free to comment. Just raise your hand and we'll get to you in order.
Blake, I've seen Susan Peasy's hand up for a long time. I don't know if you're not seeing that or maybe it's down. It's just showing up on me.
I am not seeing it. Susan?
It doesn't show up on mine either.
Yeah.
Susan, do you want to make a comment?
Hi, this is Susan Peasy, and I did not mean to have my hand up, and I am sorry if it came up. So my public comment is thank you all for all the presentations.
Okay, any other comments? Okay, final call. Okay, let's go ahead and move on to agenda planning, which is a new section that we have built in from the ideas of the committee members. So next, if you want to pull that up, Michelle.
Yeah.
Just give you a second.
So yeah, I put this document together to help me track what is what we've covered already, what's coming up, and just make sure that, you know, throughout the year we're covering the high priority items for you all. So here's where we are, February 13th. Coming up next month, March 6th, we've got the RNP quarterly report review. So that'll be Q4 from 2022. And then we've got a few more housing program presentations. So as Melody mentioned, she'll be coming back to do a presentation on Apple Health and Homes. We've got Matt Christie to cover foundational community services, supportive housing, and then Housing First with Lisa Bennett Perry, and Heather Maxwell Reichart will do Oxford House program. So there's several more housing presentations coming up for you. So there's that, and then potentially an update on where we're at with the request to add new seats of representation and committee chair. April 3rd is, sorry, I'll stop there. So that's where we have for March 6th. Does anyone have that? It seemed like that was full, like that's a full agenda already. So I was going to move into April 3rd, but want to just open up to feedback for the next month agenda, March 6th, before moving on to April. Okay. So then in April, we have some of the other things that were requested for conversation and discussion, like wanting to talk about addressing stigma. Media and messaging was something that came up, talking about the Safe Supply Work Group and talking about the SUD Initial Engagement Measurement Work Group, and things like that. So if there's any additional comments or requests about how we're putting the agendas together in the future, yeah, please, Malika, go ahead.
So I hope we're on the April meeting, we're not looking to do all 4 of those things, because each one of those could be a separate meeting. And if we're going to actually do justice by them, I would hope that we could have some really deep dives. I just have a request under the addressing stigma portion, because part of what we're seeing today, like with all the questions that we're asking around data, and I'm not saying this as a judgment of anybody, but that is the way that stigma, or the stigma perpetuates the way that we collect data, and the absence of the things that everyone is asking about, that is a representation of stigma. So I'm wondering if we can talk about, like, have part of that addressing stigma conversation be about alternative data collection mechanisms that can start to address stigma, like ways that data collection, the manner with which we do it, the process with which we identify what is going to be collected. Because I don't know about the rest of the folks on the committee. I just feel like, and it is not okay. And I'm saying this generally, I'm not casting this at any individual. We are beyond the time in our society, in my opinion, where it is acceptable to say we just don't know because we don't collect that data. We haven't asked those questions. We need to do better. And I'm not going to give up on, even though things didn't work out the way that I wish that they would have as far as this process is concerned. I will continue to push and probably make some of y'all real upset along the way, and I don't care. Anyway, we need to do better. We need to be moving the ball forward on how we are addressing stigma and how we are analyzing what we can do better as far as data collection, to start actively changing the stigma within these processes. So learning alternative data collection mechanisms, the information that we're missing that everybody keeps talking about, where are some places that have started addressing that with the way that they collect data? What can we learn from them?
Thank you so much, Malika. I know that you had just said, we need people there who have addressed this issue and are doing well on that front. Do you have anyone in mind that you would like to be at that meeting for that discussion? Or if not, that's fine. We'll figure it out and we'll try to have the right people there. But just offhand, if you, or anybody else, if you know someone who's doing well on this front, let me know and we'll get them there.
And to be clear, like I said, I don't think anybody has arrived. I don't think anybody's doing super well, but I think that there are places that are doing better. And since we're in the process of designing something more holistic, why can't we learn from what's happening in other places? I would tap Caleb because I imagine he probably knows some things as well, but I see Kevin has his hand up.
Go ahead, Kevin.
Yeah, I agree wholeheartedly with Malika. This is going to increase the landscape and make it totally inclusive if we truly appreciate all the data that needs to be collected from everyone that's included in this population. But one of the key members of the population where stigma often gets, does this apply, is with our youth. So I know Michael's brought this up on many things when it comes to how legislation apply. I mean, specifically with our safe supply initiatives, those sorts of things. How is this going to apply to youth? Stigma as it applies to youth. What's the definition of stigma? For me personally, stigma with kids is different than stigma with adults. Okay, I can, I work in the mental health space as well, and with youth we can kind of cross over there, but with the persons dealing with substance abuse disorder or substance abuse issues, sometimes kids kind of need to be called out in order to address, in my mind, more of a serious issue that speaks more to their home life and things like that. I don't know. I think the whole youth discussion needs to be a part of it. Thanks. My thoughts might have not been totally clear on that, and for that I apologize, but I think kids need to be talked about. Thank you.
Yeah. Absolutely. Thank you, Kevin. All right. Let's see. And so Malika, I agree with your comment from earlier that each of these are big topics, and trying to squeeze them all into one meeting will probably not be super fruitful. So are there thoughts about, sending out a survey of sorts to in between, between now and the next meeting for folks to rank priority these different conversations, and so we can tackle them one at a time in subsequent meetings. I want to make sure that we're, bringing in everyone's opinion and gathering what's important to you all and the order in which you want to talk about these things. And I think there's enough meeting time, throughout the year to get to it all, but just want to figure out how to determine the order of those conversations. Any thoughts on that? Any thumbs up if that sounds like a good plan? All right, I'm not getting any feedback on that, so I will not do that moving forward.
You got a few thumbs.
Oh, we did. Oh, okay, sorry, I didn't see them. All right. All right, well, we'll go ahead and try that out then. So if there are other things that you want to address in conversation this year that you don't already see, and I'll send out in an email, the different topics that we're looking at, but I just want to make sure that we've collected them all so that we can begin prioritizing, because the agendas are going to fill up fast. So please let me know what else you want to make sure that we cover.
Malika.
Yeah.
I don't know if the chat is weird today, so I don't know if people can see what I just put in there, but just to piggyback on what Kevin Ballard was saying, the Healthy Youth Survey, doing a review of the as it relates to the topics that we are working on and social determinants of health with youth, and then doing some potential cross-section analysis of the report that was just released I think it was just released anyway. I read an article, I think in the New York Times today, about the youth survey that the CDC did, and talking about the increase in suicidality and substance use, violence, all of these different factors that are impacting youth. I think that we can't just look at any of this for any of the people that we're talking about within a vacuum, but we definitely can't with kids either, youth either. So I would hope that we would have a whole meeting dedicated to that and to that discussion, at least a whole meeting. And I think that it could be prudent for us to look at the same things with adults and then do some cross-section analysis potentially in another meeting, so that we're really getting that's what causes all of the things that we're talking about, right? And we have an opportunity to move beyond just looking at substances and look at whole people.
Michelle, we can bring in Healthy Youth Survey, and also we have a young adult survey, Malika, that we commissioned out of University of Washington. So more than happy to share that information.
Mm-hmm.
All right, Addie.
Hi, thank you. I want to also put my chips in for talking more about youth, because for many people, substance use disorder is a disorder that begins in adolescence. We talk about it as an adult disorder, I think, because for a lot of people, that's when a lot of the really lasting sequela of consequences come. But for many people, this is a disorder that starts in childhood, and we should be talking about it that way.
Thank you. Okay, any more on the agenda piece? I guess good feedback, thank you. Okay, Michelle, you want to wrap us up?
Yeah. All right, so before we conclude the meeting, I just wanted to loop back with folks about one of the items from the last meeting. There was a member request to learn more about one another and the work that different committee members are doing outside of the SURSAC. So to respond to that request, we thought it would be helpful to create a SURSAC member directory. And you received a few questions of prompts to write a short bio for that and send in a headshot. And so I could put that together. I haven't gotten many responses so far, so I just wanted to kind of gauge interest in even participating in that or creating that. So if you intend to respond, you know, and we can extend the deadline there, you know, setting it for this Friday, that can be extended if you need more time. But if you could put a comment in the chat or raise your hand if you intend to participate in that, then it will help me know whether that's something that we're going to move forward with, or if you should we should figure out another way. All right. So I see a few hands up from members. Okay. All right, so it looks like, yeah, that there's some interest. So we'll go ahead and move forward with that. And if it's just a handful of folks, you know, that's fine too. It's definitely optional to participate. So great to know a bit more about whoever's willing to share. And with that,
Michelle,
I think, yeah.
I'm sorry, can we open that up a little bit? I think with 20 some members, if 5 have their bios out there, even though it's not, you know, compulsory to do it, I'm not sure we're hitting the intent of the request. So there's, I feel like there's maybe more below the response than what we've seen. Do we want a directory that has 5 bios and 20 not?
Right.
Or
right.
Or yeah, are there other questions or fewer questions or a different way to address what the request was? And very open. I mean, this is very open that people's feedback.
My thought is if there's less than half of the members participating, it wouldn't become an official directory, and we would just talk about how to share that information, if at all. But yeah, curious to hear what other folks think about that.
I think just finding time for a response has been a barrier for me, so definitely would appreciate an extended deadline, but definitely want to participate.
Yeah, I second that. It's been a very busy period with all the stuff coming out and all the responses and stuff. Going down to Olympia.
Michelle, would you be able to send that out again? I don't even remember seeing that come across my email.
Yeah, absolutely.
Thank you.
Do we have a hand still up there, Paul? Did you want to? Oh, okay, it was just for that. Okay.
Does that give us enough direction, Michael, for the directory?
Yeah, I think we put out an extra month on it or something, Michelle, and then see what kind of response we have, and we'll bring it back here. If you guys, you know, if you want to publish something with a handful, or maybe we'll get, you know, a lot more in that time. But sending out a discrete email as a follow-up sounds like it's what people are asking for. That's good.
All right. Well, we've got the next meeting agenda all set, and I'll send out that prioritizing survey for the remaining things for future meetings. And I think that wraps things up. Thank you all.
Okay. Thanks, everybody. Really appreciate the presentations, those that provided them, and the engagement by members, and certainly facilitation by Blake and Michelle, all your preparations. So thank you, everyone. Have a great day.